in conducting a delivery. What one should do? One need not get panicked, but one should contact the expert immediately.
In spite of all these precautions, if at all an accident occurs, do not panic. Deglove immediately. Remember, do not squeeze. Do not suck. Allow the blood to flow out naturally. Hold the part under running water. Wash profusely with soap and water. You may then apply any disinfectant such as alcohol or dilute glutaraldehyde. In case of mucosal exposure, wash thoroughly with plain water. Do not use disinfectants, especially in the eyes. The standard protocol in case of accidental exposure should be followed. Confirm the serostatus of the source case. If the test is negative, do not do anything. Do not worry. If the source case is positive, test the healthcare provider for HIV. If this test is negative, consider post-exposure prophylaxis. If positive, it means that the healthcare provider is already infected. Counsel the healthcare provider and link to proper care. Remember, most occupational exposures do not lead to infection. Assess the risk depending upon the type of the injury, type of instrument, amount of blood or body fluid transferred, and patient's disease status. Depending upon the risk assessment, appropriate post-exposure prophylaxis regimen is decided. Post-exposure prophylaxis should be started immediately, ideally within first few hours. Efficacy of post-exposure prophylaxis started after 72 hours of exposure is debatable. The healthcare provider should be retested for HIV after 6 weeks, 12 weeks, and 6 months following exposure. During this period, the healthcare provider should refrain from donating blood, semen, or organ tissue and adapt safe sex practices. Inform all accidents to the authorities and maintain a register of occupational exposure incidents. In case of hepatitis B exposure, post-exposure passive as well as active immunization is recommended for an unvaccinated healthcare provider. It would, however, be in the best interest of all healthcare providers that they get vaccinated against hepatitis B. The risk of accidental transmission of HIV is extremely low. Taking proper precautions can reduce it. Post-exposure prophylaxis reduces the chances substantially.
Care is denied to HIV-infected women in many obstetric hospitals, feeling that they don't have the facilities to isolate these women in their hospitals. Is there a need for isolation of HIV-infected women or HIV-infected patients in the hospitals? I can assure you that there is absolutely no need to isolate these persons in our hospitals. For obstetric hospitals, there is no need for having separate labor rooms, separate operation theatres, or separate wards for these women. We also understand that there is absolutely also no need to fumigate the rooms or fumigate the operation theatres when a procedure is done on a HIV infected woman in a hospital. HIV does not spread like this. Isolation would be required only if these women have any other condition which requires isolation for their medical problem. Between two cases, if there is a HIV infected person operated upon in an operation theatre or has delivered in a labor room, only surface cleaning is good enough before a next case is done. We should overcome our fear and do all the procedures and provide care to our HIV infected women in our routine setups.
For all pregnant patients and patients coming to us for delivery, we try to give them best of the care. All pregnant patients are same to us. There is no discrimination whether the lady is HIV positive or HIV negative. We try to do our best in each and every antenatal patient. There is one more responsibility as a healthcare provider which we have is to maintain some secrecy. some confidentiality about their status also, and that also we do respect. We have been delivering HIV positive patients for years now. Initially, we did have apprehension about getting HIV transmission, getting infected, but over the years we have realized that this fear is not very true.
In my clinic, we routinely take care of patients who are retrovirus positive. I feel that it is morally and ethically wrong to discriminate against such patients, and it is our duty to take care of these patients antenatally, intranatally, postnatally, and take care of their children as well. To discriminate is to ensure that the disease spreads further, and we should not be doing it.
We are now all moving towards elimination of pediatric HIV. At this juncture, I am reminded of story of Elizabeth Glaser. In 1981, at the beginning of the HIV epidemic actually, Elizabeth received a blood transfusion during her first pregnancy and got infected because of HIV. The transmission occurred to both her children later. In 1986, she could not save her daughter because no medication was available at that time. She realized that whatever medicines are being discovered and distributed were being given only to adults, and there was no pediatric AIDS research. With the help of a few friends, she established Pediatric AIDS Foundation. In 1994, she lost her own battle against HIV, and the foundation was renamed Elizabeth Glaser Pediatric AIDS Foundation. This foundation is right now supporting programs for prevention and treatment of HIV as well as research on pediatric HIV in many countries, especially in Africa, and saving millions of lives of children by providing prevention as well as treatment. Elizabeth Glaser's son is now a young adult and is contributing to the cause of Elizabeth Glaser Pediatric AIDS Foundation. Elizabeth, when she first realized that her children are HIV infected, had said, "The only thing worse than knowing your child is HIV infected is to know that it could have been prevented." Friends, in our country, who can prevent transmission to the children? It's we who can do it. The international goal is moving towards zero. Zero transmissions, zero deaths because of HIV, and zero discrimination. Friends, we can do this. Let's join hands.